The MONALEESA-3 trial was recently published and presented at ASCO. And this trial was a little bit different than the other trials in that it allowed both first and second-line endocrine therapy. The endocrine therapy was fulvestrant, and patients were randomized to either placebo or ribociclib, 600 milligrams a day. This design was motivated by recent data showing that first-line fulvestrant may be a little bit superior to first-line aromatase inhibitor. And this trial, the FALCON trial, the most recent of these trials, was done in patients who had not had endocrine therapy in the metastatic setting. And what that trial showed is that overall the progression-free survival was better with fulvestrant, particularly in patients that had non-visceral disease. So on that basis, there was an interest in exploring combinations with CDK4/6 inhibition. And this trial enrolled about half of the patients in first line and about half in second line, and showed very similar results in terms of the hazard ratios, with a doubling of progression-free survival. In fact, it was a little bit better than you would have expected, given the fact that half the patients were receiving treatment in second line. The toxicity profile was very similar to what had been described before, mostly neutropenia and only 1% febrile neutropenia. There were a few cases of liver function abnormalities in QT prolongation, but none that resulted in long-term problems. In fact, there were no clinical consequences of a QTc prolongation. So, in the opinion of Dr. Slayman that presented the data, the benefit that fulvestrant may have just as a single agent may really make this the preferred first-line therapy for patients in partnership with a CDK4/6 inhibitor, or if one is using endocrine monotherapy. And one should use other factors in making these decisions. For example, is there a concern that the patient may not be compliant, and might fulvestrant be a better option? Or would the patient be averse to receiving monthly injections? So these are other factors that should be used in the decision. When one is considering the hormonal therapy partner, whether it's with a CDK4/6 inhibitor or with everolimus, or whether one is considering endocrine therapy alone, I think one has to look at the differences between these agents. Now, the data that we have with fulvestrant compared to aromatase inhibitors, granted, is with single-agent therapy. So I think that's where you can most reliably use the data from the FALCON study, for example, in maybe using fulvestrant first, especially in the patient that has not received endocrine therapy in the advanced setting and who has non-visceral disease. So in that setting, I think one can confidently say which is a better partner. Now, by extension, one might assume that if you're combining it with a CDK inhibitor, that the same will hold, and that fulvestrant might be a slightly better partner. And the MONALEESA-3 study provides evidence of that, but not the kind of evidence that you would have with a randomized trial dedicated to that. And those trials are underway. But again, as clinicians, we have to use the available data to make the best decision. So if I find a patient that really has equal options for fulvestrant in terms of preferability and injections and whatnot, I think I would favor that, particularly as the endocrine partner in someone with non-visceral disease.